moving right along with glomerular disorders. It's kind of a hard word to say quickly. Here we go. We know it's inflammation of the glomerulus. Most common can be immunologic abnormalities. Drugs or toxins that we know that can destroy the filtering system of the kidney. Vascular disorders, a lot of blood goes through here, so if we've got problems with the heart and or lung, we can have kidney problems. Systemic diseases and viral causes. I want you to know that glomerulonephritis is the leading cause of chronic renal failure and end-stage renal disease. And, okay. So now that we know all that about the glomeruli and glomerulonephritis, let's look at acute glomerulonephritis. It's associated with a strep infection. Believe it or not, it has an abrupt onset, 7 to 10 days post a strep infection in your throat. We're all very familiar with that, and I don't know if you're familiar with the skin or impetigo, but that's caused by strep. And somewhere along the line, an antigen-antibody reaction causes damage to the glomerular membrane. This is most common in boys ages 3 to 7, but it can occur at any age. Up to 95% of children and 70% of adults recover fully. The elderly may progress to chronic glomerulonephritis, and that occurs between the ages of 50 and 60. But I can't stress enough, if you have a throat infection, you need to go have it cultured, because sometimes people don't go to the doctor, and if it is strep and it's not taken care of, they can end up with kidney damage. Make no mistake, strep is a vile bacteria. Signs and symptoms, anywhere from 10 to 3 days. Again, it usually comes in the skin with impetigo or strep throat, so it doesn't happen overnight like simple bladder infection. There can be blood in the urine. It's usually hidden. Red blood cell casts, protein in the urine, a decreased GFR, makes sense, right? Because that's in the center of the kidney. It's not going to be filtering like it's supposed to. Hypertension, edema, periorbital can be in the face or dependent in the ankles. They can have dark, smoke-colored, foamy urine, oliguria or anuria, meaning a small amount of urine. Oliguria. Anuria is none. Nocturia at night. Hypertension, they can have shortness of breath, a cough, fever, pain, confusion, seizures. They diagnose this with a urine analysis, which in the urine would be hematuria, leukocyturia, proteinuria, elevated BUN and creatinine, there it is again, and potassium levels are elevated. Remember, with any kidney problem, potassium level can go up in the blood. IVP and intravenous pyelogram is a diagnostic test where they go in through your IV and they can light up the entire kidney tree. Urinary tract tree is what we call it, how it goes up and in and then out into two kidneys with a dye, just to see what it looks like. But it may reveal an altered kidney size. Chest x-ray may reveal pulmonary congestion. How do they treat it? Bed rest, usually in a hospital with a lot of antibiotics. Restriction of fluids because we've got a sick kidney. Sodium, potassium, and dietary protein. Corticosteroids, the prednisone, to suppress inflammatory responses. Antibiotics to treat infection. A lot of times ACE inhibitors for proteinuria and to control hypertension. Diuretics for edema. Dialysis or kidney transplant if it progresses to end-stage renal disease. Again, treating the primary cause, an antibiotic for 7 to 10 days, contributing to the ongoing antigen-antibody response, anticoagulant to control fibrin crescent formation, fluid restriction. I think we already talked about with the fluid restriction, we're going to put them also on a sodium restriction. We don't want them to become hypernatremic. Correction of electrolyte imbalances, and we're primarily going to be looking at potassium and a corticosteroid. Fluid restriction, a lot of times because they're going to have edema. And sodium, we want to prevent fluid restriction or retention with sodium. So we're going to restrict that. And again, the corticosteroid inflammatory response, we're going to decrease that antibody synthesis to suppress the inflammation. So then we'll move on to chronic glomerulonephritis, related to a variety of diseases that cause deterioration of the glomerulus itself and progressive loss of renal function. Causes, there is our lovely word of autoimmune, is like, why all of a sudden this is happening if we don't have a reason? Unknown are secondary causes, diabetes and lupus. Chronic inflammation of the glomerulus, that would be a cause. Progressive course leading to chronic renal failure or nephrosis. Lab tests, again, BUN, blood urea nitrogen will be 100 to 200 milligrams per DL. Normal BUN is 10 to 20. So there you have it. The kidney is in big time trouble. Creatinine elevated greater than 6. Normal is 0.6 to 1.2. Okay, now we're going to talk about nephrotic syndrome. And this one is not a disease. It is a group of symptoms. And the biggest thing is the protein. When we see an excretion of 3.5 grams or more of protein in the urine per day, this protein excretion is due to glomerular damage. The findings, we have hypoalbuminemia because we don't have any protein in the blood. It's all gone. We have edema, we have hyperlipidemia, lipiduria, meaning we've got fat in the blood, fat in the urine, decreased vitamin D. We have marked proteinuria, hypoalbuminemia. Edema characterize nephrotic syndrome. So marked, meaning a lot of protein in the urine, hypoalbuminemia, hyperlipidemia, and edema characterize the nephrotic syndrome. That's why it's a syndrome. We've got more than one or two entities going on. It's associated with low serum protein, high serum cholesterol, and generalized edema associated with functional damage to the glomeruli. It's more common in children than adults. Albumin is lost in the highest concentrations with nephrotic syndrome because of its high plasma concentration and low molecular weight. Loss of albumin stimulates lipoprotein synthesis by the liver and hyperlipidemia. Decreased dietary intake of protein from anorexia or malnutrition or accompanying liver disease may also contribute to lower levels of plasma albumin. Decreased vitamin D is due to loss of serum proteins and decreased vitamin D activation by the kidney. Alteration in coagulation factors may lead to a thromboembolus. So this is tough stuff, nephrotic syndrome. And how do we diagnose it? Well, we do a 24-hour urine, meaning we need every drop of urine because it's measured and we need to know the amount of protein or we don't have a nephrotic syndrome. So we've got a 24-hour urine, greater than 3.5 grams of serum albumin. And that's what we find in the urine. That's simple. That's it. That's how we diagnose it. And so it looks like a big container, like a milk container that they bring in from the lab. It's a special container, and every drop of urine for 24 hours needs to go in there. So if the patient needs to be educated on that, if they're with it, and there needs to be a big sign in the bathroom, a big sign on the door, so that every nurse or every CNA, everybody going in there helping this person is going to put every drop of urine. If we miss a urine, we've got to call the doctor and start it over. And people aren't going to be happy because they need every drop of urine. So that's very, very important. Treatment, normal protein but low-fat diet. They usually restrict them for salt because of the fluid that's being retained. Diuretics, but give them very slowly because we've got a sick kidney here. Immunosuppressants, heparinoids, so they don't get a blood clot to prevent clot formation. Edema from nephrotic syndrome does not respond to diuretics. So we're still going to try to keep the kidney empty of fluid. Steroids to reduce the inflammatory response. Aldactone is usually given with loop diuretics to suppress aldosterone activity. And the reason is we want to conserve the potassium. Again, I'm going to say that again. We know aldactone holds on to sodium. So aldactone, usually given with loop diuretics, aldactone, aldosterone. We know aldosterone hangs on to sodium. So we give aldactone, which is a form of a diuretic, and we give it with the loop diuretics, which is usually Lasix, to suppress aldosterone activity to conserve potassium. So I'm going to say that again. We're trying to suppress aldosterone because we don't want it to hold on to the sodium or the fluid, but we need to conserve potassium. So if we have a high sodium, we're going to have a low potassium. So we're going to have aldactone with a loop diuretic to suppress the aldosterone, which would suppress the sodium to conserve potassium. The prognosis varies. It depends on the underlying cause. Okay, then we're going to talk about renal failure, which is basically renal insufficiency. We've got acute renal failure, and it's 3 phases: pre-renal, intrarenal, and post-renal. Pre-renal is the most common cause of acute renal failure. It's caused by impaired renal blood flow. And so we know that can be caused by antihypertensive meds blocking angiotensin-converting enzyme inhibitors and angiotensin receptor blockers, which we'll talk about a little bit later. Arrhythmias that cause reduced cardiac output, arterial embolism, arterial or venous thrombosis, ascites, fluid in the gut is going to interfere with circulation, burns, cardiogenic shock. You notice a lot of the things I said had to do with blood being diverted or being trapped or being narrow vessels. Arterial or venous thrombosis, dehydration, eclampsia from pregnancy, which will cause seizing, heart failure, hypotension, hypovolemic shock, malignant hypertension, not hyperthermia. This is a difference. This is very severe hypertension, a heart attack, MI, or sepsis. Intrarenal is acute tubular necrosis, and it's the most common cause of intrarenal failure, and it occurs most often after surgery, 40 to 50% of cases, but is also associated with sepsis, OB complications, severe trauma, including severe burns, and nephrotoxins. Hypotension is associated with hypovolemia, produces ischemia, cell swelling, injury, and necrosis. Acute glomerulonephritis, acute pyelonephritis, acute tubular necrosis, crush injuries, myopathy, renal myeloma, scleroderma, sickle cell disease, and systemic lupus can all cause intrarenal failure. And then postrenal occurs with urinary tract obstructions that affect the kidneys bilaterally. Postrenal BPH, or benign prostatic hyperplasia, bladder obstruction, or ureteral obstruction. So postrenal is pretty easy to understand. Actually, they all are. Prerenal is, again, impaired renal blood flow, so anything in the circulation. Intrarenal is you've got tube damage. And postrenal is mostly obstructions. Okay, that is our third video completed, and we'll have one more hopefully, and that'll be it for our kidney dysfunction.